Welcome back to The Explainer. Before we dive in, please take a quick second to like, share, and subscribe to the channel so you never miss out on these deep dives. Okay, today we're taking a spatial journey right through the hepatobiliary system. We're going to track the fascinating flow of bile, literally from its creation all the way to its final destination. So here's a question for you. How exactly does the liver deliver its digestive fluid to the exact right place at the exact right time? It's this wild physiological mystery that plays out inside your body every single time you eat. I want you to think of the biliary tree not just as a bunch of static tubes, but as a dynamic, intricate river system. It's got springs, little streams, a main river, a reservoir, and even a dam. Let's see how we're going to navigate this river today.
All right, here is our roadmap. Number 1, the journey of bile. 2, gallbladder anatomy and function. 3, adjacent anatomical relations. 4, Cablett's triangle and surgery. And finally, number 5, common biliary pathologies. Let's jump right into section 1, the journey of bile, from the liver down to the duodenum. Okay, so the springs of our river are the hepatocytes in your liver. They produce and secrete bile into these tiny microscopic channels called canaliculi. You can think of these as the smallest little streams. Now these streams merge together into intralobular ducts, then interlobular ducts, and they eventually form the right and left hepatic ducts. Those merge into the common hepatic duct, which then joins up with the cystic duct to become the mighty common bile duct. Ultimately, this main river empties right into the duodenum, which is the very first part of your small intestine.
But this river doesn't just flow unchecked, right? It actually has a dam, elegantly known as the sphincter of Oddi. This is a specialized muscular valve located right at the duodenal papilla. When you aren't eating, this sphincter is closed completely tight. And because that dam is closed, the flowing bile literally hits a wall. It has nowhere to go, so it reflexes, or backs up, into the cystic duct and straight into the gallbladder to be stored for later. Moving on to section 2, gallbladder anatomy and function.
So the gallbladder itself is this pear-shaped sac sitting super snugly in a fossa right beneath liver segments IV, B, and V, and we generally divide it into 3 main regions. First, you have the fundus, which is that rounded distal projection that often peaks out just beyond the inferior border of the liver. Then there's the body, the largest segment. This part is highly expansile, meaning it's literally meant to stretch out as it fills up with bile. And finally, we have the neck, which tapers down proximally to connect right into the cystic duct.
Now let's zoom in for a second on a really specific anatomical landmark. It's called Hartmann's pouch, or the infundibulum. This is an asymmetric mucosal pouching right at the transition zone between the gallbladder body and the neck. Clinically speaking, this isn't just some quirky shape. This specific pouch is actually a notorious trap. It is precisely where gallstones frequently become impacted and cause some serious blockages. So, while that bile is just sitting in the gallbladder, it doesn't just stagnate, it actually transforms. You see, hepatic bile, fresh from the liver, is quite watery, but the gallbladder has this highly specialized mucosal layer covered in microvilli, and it actively reabsorbs water and small electrolytes. By doing this, it concentrates the bile up to 5-fold. It's essentially packing all those essential organic molecules, like bile salts and cholesterol, into a much tighter, significantly more potent space.
And we absolutely need that storage and concentration capability. Why? Because 400 to 800 milliliters is the sheer volume of bile an adult human liver produces every single day. I mean, that's nearly a whole liter of digestive fluid. It really puts into perspective just how incredibly active and vital this river system actually is.
So you might be wondering, how does the body know exactly when to release all this concentrated bile? Well, enter CCK, or cholecystokinin. When you eat a meal, especially one that's high in fats, specialized cells in your duodenum detect those fatty acids and release CCK straight into your friend stream. This hormone is like a master synchronizer. It tells the gallbladder to forcefully contract, squeezing out the bile, while simultaneously telling our dam, the sphincter of Oddi, to relax and open up. The timing is just perfect.
All right, let's head into section 3, adjacent anatomical relations.
Let's map out the highly complex 3D relationships going on here between the duodenum, the pancreas, the vascular structures, and the extrahepatic bile ducts. It's like a 3D puzzle. Notice how the first part of the duodenum sits directly posterior to the gallbladder, but anterior to the common bile duct. And then the second part of the duodenum physically wraps around the lateral edge of the pancreatic head, which is where the bile duct ultimately enters. It's an incredibly tight, interwoven space in there. To really reinforce that spatial mapping, let's look at what the gallbladder physically rests against in the right upper quadrant. Superiorly, it's touching the liver. Posteriorly, it's related to that superior duodenum we just talked about, as well as the hepatic flexure of the colon. And inferiorly, it sits right next to the transverse colon. Because they are practically hugging each other, any inflammation in the gallbladder can easily spill over and affect all these neighboring structures.
Okay, section 4. Calot's triangle and surgery.
Whenever a surgeon goes in to remove a gallbladder, they absolutely have to navigate a very specific anatomical space known as Calot's triangle, or the hepato-cystic triangle. The modern boundaries are pretty clear. Medially, you have the common hepatic duct. Inferiorly, the cystic duct. And superiorly, the inferior surface of the liver. An easy way to remember this is to use a mental picture of a CCI triangle, common hepatic, cystic, and inferior liver surface.
But why is this triangle such a big deal? Well, it's all about what is hidden inside it. This compact space contains the right hepatic artery, the cystic artery, which feeds the gallbladder, and the lymph node of Linde. The surgeon has to meticulously dissect through this area to clip the cystic artery and the cystic duct. If they don't know exactly where they are, they run the risk of causing severe, life-threatening bleeding by accidentally cutting that right hepatic artery.
And just to make things even more complicated, textbook anatomy isn't always reality. Did you know that cystic artery variations occur in roughly 20% of cases? In fact, up to a quarter of people might actually have double cystic arteries. Failing to recognize these aberrant origins during a laparoscopic procedure can lead to catastrophic surgical hemorrhage. It's definitely not something you want to miss.
So, to combat these wild variations and prevent devastating bile duct injuries, modern surgery relies on a vital gold standard called the critical view of safety. Popularized by Dr. Strasberg, this requires the surgeon to carefully clear out the fibrous tissue in Calot's triangle until they can definitively identify exactly two tubular structures. That's the cystic duct and the cystic artery, leading directly into the gallbladder and absolutely nowhere else. They also have to dissect a third of the gallbladder off the liver bed. Only then, and I mean only then, is it completely safe to cut.
Which brings us to section 5, common biliary pathologies. What happens when the river gets blocked?
Well, it almost always starts right here with cholelithiasis. That's the medical term for the formation of gallstones within the gallbladder. Basically, due to imbalances in cholesterol, bile salts, or bilirubin, the bile literally crystallizes. These stones act exactly like solid debris sitting in our reservoir. Now, they can be completely silent and sit there for years, or they can cause some immense trouble.
If that debris decides to move and get stuck in the narrow exit, the cystic duct, you get cholecystitis. This is inflammation of the gallbladder. Because the duct is fully obstructed, the bile becomes stagnant. The gallbladder wall gets irritated, it swells up, and it can eventually become infected. This is exactly what causes that intense, prolonged pain in the right upper quadrant that patients complain about.
But what if the stone is actually small enough to make it past the cystic duct, only to get stuck further downstream in the main river? That is choledocholithiasis, which is a stone lodged in the common bile duct. Because it's blocking the main drain, it causes huge systemic backups. It literally forces bile back up into the liver, elevating liver enzymes and bilirubin, which causes jaundice. And if it blocks the pancreatic duct near the sphincter of Oddi, it can trigger pancreatitis, elevating amylase and lipase. Just one little stone can disrupt the entire digestive network.
Which brings us to a final thought for today's explainer. If a surgeon safely navigates Calot's triangle and completely removes a diseased gallbladder, the reservoir is just gone. So, how does this dynamic river of bile adapt to keep your digestion flowing smoothly without its storage tank? The human body's adaptability is truly a marvel, and it's definitely something to chew on until our next explainer. Thank you so much for joining me on this spatial journey through the biliary system. Please remember to hit like, share, and subscribe, and keep that curiosity flowing.